So from esophagus, this is the patient day 2 corrosive, and this is a presenting complaint. Okay. So this was a repeat question. Investigation, do proper evaluation staging. Corrosive is a hot topic for your INISS. Every time you will get 1 or 2 questions from corrosive. So be very thorough with corrosive. Sorry. Okay, sorry. Yes, this is a question. Yeah, bronchoscope is not needed. Now, this patient has a history of acute corrosive, second day of illness, and you can do endoscopy because we don't do endoscopy after 3 days. So this is okay. CT scan, if you see, if you read the recent Shackelford, what they have mentioned is now or less, more or less, we do CT scan in all patients. CT scan is kind of mandatory if you ask me in acute corrosive. If they ask you what is one investigation you'll do in a patient with acute corrosive, and if you have 4 options, the answer would be obviously a CT scan. So if you read the recent Shackelford, they have clearly mentioned that CT scan, yes, it has not replaced endoscopy, but what they say is that there are some limitations of endoscopy. And I'll tell you what are the limitations of endoscopy, where you should not do upper GI endoscopy. And even in our training days, my professor would say that, why do you want to do endoscopy? Because if the patient is clinically stable, you are not going to do anything. You are just to have to manage conservatively. And the patient has a perforation, obviously you will not do endoscopy. If the patient has a grade 3 injury, you will pick on a CT scan. So why don't you want to put a scope in a grade 3 patient? Okay, it will not change your management. But anyways, that is a different thing. If you read your new books, what they say is a CT scan is mandatory. Endoscopy, you can skip in some patients. It's basically a complementary investigation if you ask me. But for exams, if you have 2 options, CT and endoscopy, always go for CT scan because there are some limitations of endoscopy. So endoscopy you cannot do in a patient who is unstable. So if a patient has a high grade of injury, mostly he'll come to your department with some kind of breathing difficulty. The pulse may be very feeble. In that patient, you will not want to put your scope in unless the patient is stabilized. Okay, and if the patient is stabilized, then the next investigation should be a CT scan rather than endoscopy. So it's not that endoscopy will change your management per se. Your CT scan will truly tell you that it is a high grade of injury or perforation. So yes, both has to be done, but between endoscopy and CT scan, always go for CT scan. All right. And this was a question that they asked. Here bronchoscopy is not warranted, so obviously it's ruled out. So one is bronchoscopy is not. The laryngoscopy CT upper GI is a routine test. In this patient, if you see, this is a patient who is unstable. She has feeble pulse, PP is on the lower side. Okay, so here, if you ask me, one investigation where you will not do right now would be endoscopy. Okay, so you do a CT scan, laryngoscopy if you have laryngospasm, you want to see the larynx, antibiotics has to be given. But here, in these type of patients, endoscopy should not be done. So that is one thing corrosive. You have to see when you have a patient with acute corrosive, uh, what are the investigations that you have to do. One is your CT scan, that is kind of mandatory. If the patient is unstable, stable patient, do endoscopy, no problem. Okay, that is how you can remember. So what is the limitation of endoscopy? One thing is that you only look at the mucosa, so you cannot see extraesophageal complications. Suppose the patient has a small perforation, you put your scope in and then the perforation will enlarge. So that is one problem with endoscopy. And people say that is why we have to use the fiber optic flexible endoscopy. Okay. The CT scan, they say, is more sensitive to detect transmural injuries, and it is also more sensitive to detect stricture formation. So this is a recent recommendation from the World Journal of Emergency Surgery, if you call it. So this is a paper that the new book quotes that emergency endoscopy should be performed if CT is unavailable and or contraindicated or inconclusive. Suppose the patient has AKI, you don't want to do CT scan. So role of emergency endoscopy is limited where CT cannot be performed. So this is what your book also mentions, that in emergency, if given an option, do a CT scan, endoscopy can be skipped if possible. Okay, because one problem with endoscopy is that you require a very expert endoscopist. Any new amateur cannot do that level of endoscopy. You land up with a perforation. That is the second concern, because these patients generally present to a peripheral center where you don't have any access to a for a very expert endoscopist. So that is another concern with endoscopy, that it should be done by a very experienced, gastroenterologist. Otherwise, you land up with a perforation. Barium, obviously, you should not do in acute phase of illness. That is, we know that thing. This patient chest pain dysphagia, this is the barium picture. Okay, so what are your diagnoses seeing this barium? Is it achalasia, DES, jackhammer, IEM? Yes. So this is a patient who has a corkscrew esophagus. So generally we attribute corkscrew to your DES, diffuse esophageal spasm, but we know these are kind of tertiary contractions. So if you have a tertiary contraction, you have this corkscrew esophagus, and that is seen even in normal individuals. If you have a old patient, you have this tertiary contraction, and if you give barium, you see this type of corkscrew esophagus. Even in achalasia also, we see this type of picture, corkscrew esophagus. So this is not very sensitive for, not specific for diffuse esophageal spasm. So that is why if you want to diagnose DES, you have to do a high resolution manometry. You cannot diagnose DES based upon a barium picture of a corkscrew esophagus, because this is tertiary contraction, and tertiary contraction are seen in a variety of disorders, motor disorders, and even in normal individuals. If you have an old patient, you may see these tertiary contractions. So don't see if you have a corkscrew esophagus, it has to be DES. It can be achalasia also, it can be normal also sometimes. So these are different types of achalasia. This is given in your new book only. So you have a dilated esophagus and you have this tapering here. Okay. So this is classical of achalasia cardia. This they say is type 1. Here there is some amount of contraction. That is why they're saying this is type 2. And here you can see this corkscrewing effect. Okay. So this is a type 3 achalasia, spastic achalasia if you call it. So that is why once you see this appearance, this corkscrew appearance, don't assume that it has to be a DES. It can be a type 3 achalasia as well. All right. So that is why if you read the book, what they have written is these tertiary contractions are often identified in normal patients, and in those with motor disorders should not be interpreted as indicated of DES unless confirmed by manometry. Okay, so don't confuse your DES. So for DES, you have to do a high resolution manometry. And how to diagnose DES? You have to look at the distal latency. Okay, you have to look at the distal latency in more than 20% of the swallows. All right, yes. This is also very important. Remember this figure, 20% of the swallows. Questions have been asked about this 20% thing. Okay. This, I think we discussed in a group yesterday, which of the following is the most accurate measurement of treatment myotomy in achalasia cardia? A timed barium esophagram. Because a CAT score, if you see the components, these are very subjective in nature. Pain, regurgitation, you cannot say how much the patient is actually reporting. Is it true or false? So this is more of a quantitative thing. So you can actually measure the barium, what is there at 1 minute, 5 minutes, and then after 10 minutes, and you can see how much the esophagus is emptying. Okay. So this is a better investigation. So time barium emptying, this we had discussed in normal class also when it was not mentioned in your books. So this is what they say, that you take films at 1, 2, and 5 minutes. Normally the esophagus will empty within 5 minutes. And following your myotomy, there should be a 50% reduction in the height of barium. Okay. Yes, for diagnosis also. That is why it's very important. So you have a baseline value, and then you do this test after your myotomy. So you know what is the reduction in the TBE. Okay, so normally what happens is there should be a 50% reduction. So now you can actually quantify your barium emptying. So suppose the time duration was X, now it is Y, and there's a 50% reduction, then you can say that your myotomy has been done properly. So that is why they say that timed barium emptying is first very useful in diagnosis and then very useful in a treatment also. About a CAT score, if you see, you have various components which you all know: pain, regurgitation, weight loss, and dysphagia. These are all subjective. Okay, so you may say that patient may have pain, may not have pain. It's very difficult to quantify pain, difficult to quantify regurgitation. Weight loss you can quantify. Dysphagia is also a kind of a subjective thing. Okay, so maximum score is 12, and for a good myotomy, your ACAT score should be less than 3 after the myotomy. Correct. So this is also there. During your OPD visits, you cannot do a barium every time. So you use this ACAT score for your quantification, but a barium, timed barium emptying is a better test than ACAT score. Incorrect match. So these are your motor disorders and these are your pathologies, pathophysiology, if you ask me. So you all know about achalasia cardia. What is the problem with achalasia cardia? The second entity, this outflow obstruction. Okay, so this is also there in your Chicago 4 classification. So how to differentiate achalasia from outflow? Outflow will have normal peristalsis, but both share a common thing that the lower sphincter is not relaxing in both achalasia as well as your esophageal junction outflow obstruction. Now, what are the pathologies that cause this outflow obstruction? So, number one, obviously, you will have reflux esophagitis, eosinophilic esophagitis. So, these are the pathologies that can cause this outflow obstruction. Okay, people say it is achalasia and evolution. So how why is not achalasia? Because these patients have some amount of normal peristalsis. So even in examination, if they give you a clinical scenario where you see that your IES is high and you have normal peristalsis, then you have only one differential, that is outflow obstruction. Sometimes they will not give you outflow obstruction; they can give reflux esophagitis or eosinophilic esophagitis. Okay, so this is also kind of a this thing. Pseudoachalasia, you have uh, a mass effect. Okay, so pseudoachalasia you'll pick up on your endoscopy. Okay, on endoscopy, so generally, if you are thinking about motor disorders of esophagus, then obviously you have to first clarify that there should be no obstruction. There should be no mechanical obstruction. Okay, they'll only say that it is a motor disorder. So if you want to diagnose achalasia cardia, you have to do a endoscopy to rule out a mechanical obstruction. In pseudoachalasia, you'll see some amount of mechanical obstruction. So that is why it should not be there in contention for that matter. So motor disorders, if a patient has chest pain and everything, dysphagia, you do endoscopy, you don't find anything, then you think that this patient may have a motor disorder. And then you have to do a manometry to see what kind of motor disorder this patient is having. Okay. In manometry, if you see that the sphincter is not relaxing, but patient has normal peristalsis, then think about this entity which has been added in your new Chicago classification. This we know, this is true, this is true, because DES you have reduced distal latency. IEM is also a new term that they have tried to define, ineffective esophageal motility, where you have this fragmented peristalsis. Okay, so that is also true. So there are two things you have to learn here. One is your dermatomyositis, and fourth is scleroderma. Okay, scleroderma, we know it is a disorder of smooth muscle, and typically it affects your lower esophageal sphincter. Okay, but dermatomyositis, just like myasthenia gravis, it will affect your upper esophageal sphincter. Okay, so remember two pathologies here. So dermatomyositis is involvement of the upper sphincter, and scleroderma affects your lower sphincters. So just sometimes as objective question they can be asked. So this has been taken from a new book only. So this is the diagnosis. This is your pathophysiology. All right. So IEM is disorder of peristalsis, and you have this low amplitude contractions or fragmented esophageal peristalsis. The answer would be D, obviously. Okay, because dermatomyositis is a low pressure of the upper sphincter. So myasthenia gravis, dermatomyositis, involvement of the upper sphincters, and this is secondary achalasia, which we're not talking about. And scleroderma affects your lower sphincter. Okay. So remember all these things also. Secondary motility disorders of esophagus. They have not asked, so it can be asked in NEET SS also. So IEM is kind of a diffuse term. So in these patients, they have normal relaxation of the lower sphincter, but the peristalsis is a kind of low amplitude contractions. It's kind of a failed peristalsis. Okay. So it is, this thing is there in other pathologies as well. So this is kind of a diagnosis of exclusion. Okay. Yeah. Yes. So scleroderma affects your smooth muscles. So scleroderma will not affect, because we know the how esophagus is made. So upper one third is first is your skeletal muscle, then you have smooth muscles, then you have overlap. So lower third of the esophagus is almost is made of smooth muscles only. So that is why your scleroderma affects the lower third of esophagus, and that is why again a question that is often asked is which of the following secondary motility disorders will have GERD? Okay, so what happens, scleroderma, the lower third is affected. So these muscles are affected. So that is why the sphincter is kind of, either not contracting, not relaxing. So it can cause reflux of your gastric contents. So these patients will have a lot of GERD and they can have your peptic stricture as well. Okay. So this lower sphincter is incompetent in scleroderma and it leads to reflux. Okay. Scleroderma is an important thing. You should know about the secondary motility disorders as well, because primarily everyone knows the scleroderma is one that you should know. So here you cannot do a myotomy because the sphincter is already damaged. So only option is to do a esophagectomy. Some people do a fundoplication, but it doesn't work. The esophagus body as well as sphincter is affected, so it doesn't work like that. So mostly these patients will land up with a esophagectomy because of the reflux. You can have a lot of Barrett esophagus, and it is a risk factor for malignancy as well. Okay, so you cannot do a myotomy in scleroderma. The sphincter is neither contracting nor relaxing. It is a damaged sphincter. So this is a question associated with severe GERD. So GERD is scleroderma. Okay, scleroderma has GERD. So this is how your scleroderma esophagus will look like. The whole lower third of esophagus will be affected, and you have this sigmoid esophagus kind of thing. Okay, and you see this lower sphincter is also this kind of open sphincter. It will allow both prograde and antegrade flow. Yeah, so you can have sigmoid in other disorders as well. It's not very specific for cardia. All motor disorders end stage would be a sigmoid esophagus. Yes, IAM is also into GRD. Very nice. So GRD, if you have long-standing reflux disease, you can have, this acid will, injure the muscles of the esophagus, because this acid reflux, what it does, it causes myositis. So the muscles are become ineffective. So we have this IEM. So what is the implication of IEM? So if you want to, we're planning for a Nissen fundoplication, then there was a lot of debate whether if a patient has IEM on your manometry, should we do a complete fundoplication or partial fundoplication? Yes. So the thing is that even if you have IEM, so you can do a Nissen fundoplication. Unless until you have a named motor disorder, you should not do a partial fundoplication, because the outcome with a complete fundoplication is always better than a partial fundoplication. These are the indications and contraindications for HRM. Okay, so generally we do for evaluation on patients who have a diagnosis of motor disorder, but also important is we have to do before anti-reflux surgery. So that is also very important. So before anti-reflux surgery, you have to see whether the esophagus body is contracting well or not, because if the body is severely compromised, you cannot do a complete fundoplication. So this is about scleroderma. It affects the lower two-thirds of the esophagus, and you have GERD and reflux esophagitis. This is one thing. These patients are very prone to candidiasis because of stasis. They have a lot of candidiasis. So just remember, sometimes they can ask you about this. So this we have discussed yesterday also. Leak after esophageal surgery. What is the best test to do? So obviously you cannot do a barium swallow, because acute phase we don't do a barium swallow. Gastrographin is okay, we can do that. All right. So, so you can do gastrographin esophagogram, so that is okay. But the problem with gastrographin is that if the patient is not very stable and if he aspirates, the patient will land up with a pulmonary edema. No, gastrographin does not cause mediastinitis. Okay, gastrographin causes pulmonary edema. Your barium, if it leaks, causes mediastinitis. CT esophagogram, what they say is that you use iohexol. Iohexol. So iohexol is the recommended agent for CT esophagogram, water soluble contrast. So you have two water soluble contrasts. One is gastrographin, second is iohexol. So problem with gastrographin is that you may have aspiration, pulmonary edema and all with gastrographin. With iohexol, this risk is less. Okay. Endoscopy, obviously, it's done, but first you have to confirm with your all this test. Sometimes we do endoscopy also with low insufflation, but if you want to really do a test to see for leak, answer should be a CT esophagogram. Okay. So endoscopy, if you have any doubt of conduit necrosis, yes, endoscopy has to be done to see for the mucosa. But before that, you have to do a CT scan. You cannot do, generally we don't do a front endoscopy. If you have a patient that is not doing very well on day 3 or day 4, then the first thing that we do is CT scan with esophagogram. Okay. Or even if the patient is not able to take orally, you can put a rice tube and then put your contrast there. Once you have done that, then you do a endoscopy. Endoscopy should not be the first investigation if you have a leak, because if you have any insufflation, that leak will just increase. So you have to be very careful in, because they are very fond of asking this question. So you have to see what is the examiner trying to ask you. Okay, generally the question is on the what type of contrast we're using. They are not very particular about CT or contrast study. Just look at the contrast, whether it is barium, thin barium, thick barium, gastrographin, and iohexol. Okay, so that is how you have to choose. So CT esophagogram, but gastrographin problem is that you have some kind of aspiration. So if you read your new Shackelford, they have clearly mentioned that CT esophagogram scores over gastrographin, any type of contrast study, because what they say is that sometimes it's not. They have said that it's not important to give IV contrast also. You can just ask the patient to swallow. If the patient is not able to swallow, then put a rice tube, put your iohexol and take a shot. Okay, because with gastrographin or this thing, your contrast study patient has to be in seated position. There are several postures to see how the contrast is passing through. But CT advantage is that you just put your eyes to give contrast and take a shot. Okay. IV contrast, if patient does not have any renal failure, obviously you have to give, but it is not mandatory. You can just give a iohexol through rice tube. If the patient is intubated, okay, you cannot swallow, obviously. How will you do this CT scan? So through the rice tube, give the contrast, take a shot, and the patient is out. Okay, you don't have to worry about different positions. How will the patient swallow? So that is why for all these logistic regions, also they say that CT esophagogram should be the ideal investigation. If you don't have iohexol, you can give gastrographin. It's not a gastrographin is contraindicated. Only thing is that if the patient has a high risk of aspiration, we don't give gastrographin. But yes, obviously you cannot give barium. All right. Even if you're not very, fond of giving oral contrast, you can just take a simple CT scan. You'll get a lot of, signs where you can say that there is a perforation or there's a leak. You'll see pneumomediastinum, you see some kind of collection, some kind of air foci. So you have other evidence to suggest that this patient has a leak. Yes, preferred is iohexol, obviously, than your gastrographin. But worst scenario is not that we have to give contrast always. You do a CT scan, you will see some, other evidence of a leak. You will see some amount of gas, some amount of collection. So you'll know that this patient has a leak. Okay, so it's not that you have to see there's a leak of contrast. Okay, so that is why they say that you use this CT esophagogram. Okay, so this is what the book says. CT esophagogram is relatively sensitive and highly specific for detection of anastomotic leak. Allows for rapid diagnosis, always available, can be performed anytime, does not need direct radiology supervision, unlike esophagogram. Okay, CT esophagraphy should be the ideal test. Okay, it can be performed in patients who are intubated, cannot tolerate standing or semi-recumbent position for barium esophagram. Okay, advantage obviously you have a CT is that you see for extra esophageal collections and all those anatomical information if you want to have. So that is why if they ask you, CT should be the preferred investigation. If you are looking for a leak, even for esophageal perforation. So this is basically a perforation. Okay, this is a perforation. There also now they have come because if you read your previous, I think Sebastian or even previous Shackle 4, they have mentioned that you should do barium. I have read, I think, barium, they have written you should do a barium contrast study to look for perforation or even gastrographic contrast study. But this edition has clearly stated both chapters that CT esophagography should be done with your iohexol oral contrast. Okay. Barium after 4 weeks, yes, not in the acute stage. So even if we have a patient with corrosive injury, we use barium after 3 weeks. Basically, we want to look for any stricture because a thick barium gives you a lot of details about the mucosa. Okay, so barium after 4 weeks, but this CT esophagography is a very safe investigation due in the acute phase of illness. So just remember that acute phase of illness, you should not do a barium. That is as simple as that. So this, I think we had discussed, which of the following is not true. Yeah. Iohexol does not have a high risk of pulmonary edema. Okay. So no, so what they have written is, if you read your book, so this is water soluble contrast is preferred in the early post-operative period as leakage of barium can cause mediastinitis. This is okay. So high aspiration risk, use this, Omnipac, iohexol. So what they are saying is the patient has a high aspiration risk, use Omnipac. If you have no leak, so suppose you do this contrast CT scan, you do a CT esophagogram with say iohexol, and you see there's no leak. Then some centers recommend with a thin barium as there is some evidence that due to higher density and greater adherence, barium is more sensitive for detection of small leaks. So overall, barium is more sensitive for leaks. So if they ask you what is the most sensitive modality to see for leaks, that should be barium. Why they use thin barium? Because if at all there is a leak, you don't want to have a lot of extra fixation. So that is why they don't use a proper thick barium, the solution that I told you yesterday. Okay, thick barium for stricture. Yeah, thick barium is for stricture only. Thin barium, this is one place where you want to see for leaks and your other investigations are not showing any leak. But I don't see any point of doing a barium. Okay, even if the patient does not have any leak, it has to be a seal perforation. Why do you want to demonstrate a leak? That is the whole idea. So most centers will not do a barium. If you do a CT scan, no leak, you sit with it. There's no need to do a barium scan for that. Correct? Okay. So thick barium is the general thing that we use. Thick barium for your all your this thing contrast. If you want to see for the structure and all, you do this thick barium. Thin barium we do for your achalasia and all. Okay. So for achalasia and all, if you want to see, you can use thick barium. So generally the test that we use is thick barium to 50% weight by volume. Thin barium we use in all these scenarios. If you want to see for any leak, suspected leak and all, but the standard concentration should be a thick barium. If you want to see for esophageal stricture. Yes, so remember barium causes mediastinitis, gastrocalcin causes aspiration. So a lot of questions I've seen that they have tried to ask about this basic concept only. So immediate phase, we don't use barium. Immediate post-operative phase, we don't use barium. Okay. So this is about the lymph node station. This was asked in one of your papers. Okay. So this is, I think, just have to remember, if you see the Japanese classification of the lymph node stations, because they're very fond of doing this uh, esophagectomy, the three-field esophagectomy. So there are two things here. One is along the recurrent laryngeal nerve, and other is a below the tracheal bifurcation. So 106 is your recurrent laryngeal nerve, okay, and 107 is your tracheal bifurcation. Yes. So just remember that. I know what was the question exactly. I don't know whether they are asking about the below bifurcation lymph node or along the recurrent laryngeal nerve. Okay. So just remember, 106 is your RLN and 107 is your subcarinal lymph node. So 106 station is your recurrent laryngeal nerve. So if you see this thing, I've taken from the Japanese paper only. This one, not this one. So where they have clearly defined your lymph nodal stations, okay, because they do this very meticulous lymphadenectomy. If you see station 106, so 106 includes your thoracic, paraesophageal, thoracic, paratracheal, 106 recurrent laryngeal nerve. Okay, so all these 106 stations also have been subdivided. Okay, so 106 has a lot of lymph nodes. It has your recurrent laryngeal nerve lymph nodes. It has thoracic, paratracheal. So all these are included. Okay, 107 here is subcarinal. 107 is subcarinal. Okay, so you should go with 106 for recurrent laryngeal, 107 for subcarinal. Okay, you can go through this table also. Okay, I think there was one more question that was asked. Station number 113, Botalo lymph nodes. Okay, this is a ligamentum arteriosum lymph nodes in some paper few years back. What is Botalo lymph nodes? Okay, that is 113. Okay. So sometimes they ask you this also. Yeah, 104 is supraclavicular. So remember 104 also. Okay, so this table is important because they have asked previously. This is about the gastric lymph node station. This you all know, so I'm not going into that. Indications for 24-hour pH test include all except 24-hour pH test. Where should you do? Before anti-reflux, before lung transplantation, LA grade B, esophagitis, none of the above. Yes, so these are all indications. So point is that people do anti-reflux test before lung transplantation also. Yes. So they have mentioned that it causes you bronchiolitis obliterans. So before some centers do this thing, they do this fundoplication before lung transplantation. This is the only point I wanted you people to know. Rest I think everyone knows. So indicated is your non-erosive esophagitis LA grade A, B before lung transplantation. Non-indicated obviously when you have obvious evidence of reflux. So if you have Barrett's, C, D, esophagitis, peptic stricture, giant hernia, in these places there's no need to do a 24-hour PH study. These are principles of fundoplication and think the same thing. There's nothing new in that. Only thing is your fundoplication should be 2 to 3 centimeter around the distal esophagus only and should be tension free and should be floppy. The point here is that you should not have very tight fundoplication because if you have tight fundoplication, they will end up with postoperative dysphagia. Okay, so this is very important. What is the exact length of fundoplication? So this is one measurement that they have given that the fundus should be 3 centimeter from the angle of his. So just I've put the picture because it can be asked about to distance. So this fundus should be divided. So the whole length is 6 centimeter, 3 centimeter on either side. So that should be the your fundoplication length. Okay, and should be around the distal esophagus. Should not be very tight. It should be a floppy fundoplication. It is there in new book. Okay. Boogie around 52 French, that is what they put in your fundoplication. Even your cardia also 52 French boogie is standard. Surgical treatment of achalasia, false statement. Surgical treatment of achalasia. We are not asking about poem. Yes. So obviously in achalasia cardia, in myotomy, we divide both longitudinal and circular fibers. Myotomy, we know 4 to 5 centimeter into esophagus, 2 3 into stomach. Fundoplication is not mandatory. Okay. So it's not that we have to do fundoplication in all patients. Even in type 3 achalasias, we sometimes don't do a fundoplication. Okay. It's not that we have to always do a fundoplication. Even in poem, we don't do fundoplication. It does not matter that it's not important that we have to do fundoplication in all patients, right? So that is one thing that we have to remember, that fundoplication is not mandatory. Okay? Because poem works, right? Poem works very well. So in poem we don't do any fundoplication. So why won't do fundoplication in uh, Hiller's myotomy? It's thought about more specific. If you read your new book, they have clearly mentioned that mucosal perforation is the most common intraoperative complication. Pneumothorax you may have, but that is not very common. Okay, what is more common is your mucosal perforation. So, what is the length of? I have not read the new Sebastian. What is the myotomy length? What they are suggesting? In your new somebody told about the new Sebastian myotomy length. What is the new length that they are proposing? But generally, what we do is 3 centimeter into stomach, 5 centimeter into esophagus. That is the general recommendation. If you have a mucosal perforation, we have to suture it. That is how you have to manage. And then obviously, once you have a mucosal perforation, then your fundoplication becomes mandatory because it acts as a seal. Okay, that is one more reason that people do fundoplication, that the stomach lies over your mucosa of the stomach. The serosa lies over the mucosa. 6.5, 2.5. So here what they have done is they have cut short on the stomach and they have increased the myotomy on esophagus. That is interesting. I have to read about it, but doesn't make any sense to me. If at all, we know that the failure of this thing is about your fundoplex is your myotomy on the stomach. Inadequate myotomy leads to failure of Heller's. So if you want to cut short on stomach part and increase on esophagus part, actually does not make any sense to me. But I read and then basically they have must have taken from a paper or anything. But if you read a new Shackle 4, they clearly mentioned that 4 to 5 and 2 to 3. For all purpose, they will not give you that very easy option. Okay, so in poem, they will not ask you what is the indication of poem, what is so they will have a separate set of questions for poem. Okay, so poem is not that, it's not for all purpose. Okay. So there are some indications and contraindications that what they will ask you. So if you read this Cochrane Library Review, and this I've taken from a new book only. So what they have said that people have compared your Heller's myotomy with DOR fundoplication and Heller's myotomy without fundoplication. Okay, and they have found that there's not so much difference about the outcome. Okay. So it remains unclear whether LHM with DOR without fundoplication results in difference with regard to pathological reflux or severe dysphagia. So you can avoid a DOR fundoplication, especially in a type 3 achalasia. In poem, only circle is divided. The longitudinal muscles is accidentally divided, if you ask me. Okay, so sometimes it tears off. It's very small, very friable. So once you, because you're going from inside out, so once you you open the mucosa, go into some mucosa space, and you through the myotome you cut the circular muscle. So you can have a splitting of the longitudinal muscles, and this is what they call it the mediastinal exposure. Sometimes you can see the mediastinum also through that. But that is not a thing to worry. And that is why these patients after poem have sometimes have pneumomediastinum or pneumoperitoneum. Because of the splitting of the circular longitudinal muscle, the carbon dioxide will leak into the mediastinum or even the peritoneum also. And that is not a thing to be worried about because the CO2 will be absorbed. Okay. Important is that you close the mucosal defect. If you don't close the mucosal defect, then you'll have a perforation. Okay, so pneumomediastinum, pneumoperitoneum is a normal outcome, not a complication of poem. Correct? And this is a question that was asked that if you are doing a poem, post-operative, you do X-ray, you see pneumomediastinum and pneumoperitoneum. So should you do a surgeon reference or you just wait and watch? Answer is wait and watch because these are normal outcomes. Okay. Mostly we finish it around 8:30, 8:30, 15. So poem, we have to know the surgeons who have proposed. So first proposed by Parisha, it was coined by Ino. So Ino is the pioneer of poem. Okay, it's the third space endoscopy because this is the third space we are going to submucosal space. Okay, so large hiatal hernia is a contraindication. Sigmoid esophagus is a contraindication. Yes, so sigmoid esophagus is not a contraindication. So nowadays people are doing POEM even if you have a sigmoid esophagus. The only relative contraindication is a large hiatal hernia. And this question was asked in your just previous year paper. What is the contraindication for POEM? Yes, you can ask, you can tell that it is relative contraindication, but if you read your new book, they have mentioned it is kind of a contraindication because in large hiatal hernia, you will need a fundoplication. And fundoplication you cannot do in POEM. Okay. So about the large hiatal hernia, because once you reduce, because in hiatal hernia, if you have a large hiatal hernia, you have to do a fundoplication. You have to first reduce the hernia, do a fundoplication there. And this is not possible with POEM. So better to do a surgical this thing treatment of large hiatal hernia. Okay. So these are the equipments for your POEM. This is how we do it intraoperatively. First is that we have to see what is the length of myotomy we have to do. For that, we use this endoflip. That is the impedance measurement. They measure the high pressure zone here. Okay, high pressure zone. Then they do this saline lift 3 to 4 centimeter proximal to myotomy. Suppose you start the myotomy here, we have to do saline lift here. You have to cut open the mucosa, go into the submucosal space. Then you have to do the tunneling, do the myotomy, and if you split the longitudinal fibers, you have this mediastinal exposure. Then you have to always close this defect. Okay. What is the complication intraoperative? Perforation rates of 5%, close to 5%. If you're early in your career, it can increase as well. How do you manage that? We can clip it, you can suture it or stent it. Okay, so this can be asked. If you're doing a POEM, you have a perforation, what do you do? So intraoperatively, you can put endo clips here. Okay, and all these things, pneumoperitoneum, pneumomediastinum, pneumothorax, these are post-operative outcomes. They are not complications. Remember that they are not complications. These are post-operative outcomes. Yes, no, no, no. If you have mucosal perforation, then you have to close it. You cannot observe a mucosal perforation. But pneumomediastinum, pneumoperitoneum, pneumothorax, these are outcome after your CO2 insufflation. So that all these things can be observed. Okay. Success rate is 98% in some studies. GERD, if you see, 18% have clinical symptoms. But if you do a pH and endoscopy, the rate is very, very high. Okay, so people have compared LHM with POEM and the success rate is close to 80-85%. But obviously, POEM will have more reflux esophagitis. Okay. So a patient may be asymptomatic and you do a pH monitoring, you'll find that the pH demesseter score is significant, but there should be no symptoms. So that is a different thing. Okay. So for type 3, we know that POEM is better than HELLAS. So this is one space where POEM scores over HELLAS myotomy. And they have mentioned about some study published in JAMA. And what they have said that POEM is far, far better than pneumatic dilatation. Okay. Just remember the values here. They will ask you about the reflux. What is the percentage of patients who have reflux after POEM? And what is the percentage of patients who have reflux after HELLAS myotomy as well? G POEM is gastroparesis. So we have a Z POEM for Zenkel's diverticulum. So this I think is okay. Chemo prevention for Barrett's. And this we had discussed long before. Okay. So there was a landmark trial that was published and they are mentioned in the new Shackelford also. Can anybody mention the name of the trial? Aspect trial. Very nice. So all of the above basically. So PPI is all obviously we use PPI. So low-dose aspirin was in aspect trial. Statins also has some role in chemo prevention. So these are the drugs that people use for chemo prevention. Indications for anti-reflux surgery in Barrett's. This is also a very contentious issue. When do you do anti-reflux surgery in Barrett's? So if you see treatment of Barrett's is endoscopic eradication therapy. So if you have Barrett esophagus, the first line treatment is PPI. If you have any dysplasia, then you have to do a EMR because that is the current recommendation. So when do you do an anti-reflux surgery in Barrett's? Except a question should be indications for anti-reflux surgery in Barrett's are all except. Sorry, all except. So persistent reflux after eradication therapy, obviously we have to do. This is one a good indication that after eradication, patient has reflux. Large paraesophageal hernia, we have to do surgery. High grade Barrett's refractory to PPI, that is one indication. But we don't do uh, this surgery to prevent Barrett esophagus. So that is a not indication. Okay, it's not that your patient has reflux and you want to do just because you want to prevent Barrett esophagus does not make any sense. Okay, so that is not done. Okay, if you read your guidelines also, this is American guidelines. They say that recommend against routine anti-reflux surgery purely to prevent Barrett esophagus progression before optimizing medical therapy. See, a patient has Barrett esophagus. He comes to you and you say that yes, this patient has Barrett esophagus. Let me do a anti-reflux surgery. So your idea is that this will not progress to low-grade dysplasia and high-grade dysplasia. So this was done a few years back. People are doing that. But the new recommendation says that no, you first optimize this patient with PPI. If it after PPI, this is progressing, then you think of anti-reflux surgery. But here also there's a catch. So what they say is that once you have a dysplasia in Barrett's, low grade or high grade, you do an EMR. Okay. You do endoscopic eradication. So that is the first line of treatment. Even after EMR, the patient not responding, do this anti-reflux surgery. Okay, and they have described a protocol also for Manduri protocol. Okay, first optimize PPI, perform on-treatment reflux testing. If abnormal reflux persists, then do anti-reflux surgery. Okay. So that is the whole idea of Barrett esophagus. First, give PPI, optimize the patient. If you have any dysplasia, do endoscopic resection. Even after all these things, there is reflux and the patient is symptomatic, then you go for anti-reflux surgery. Correct? Risk factor for adenocarcinoma. So this is again a very repeated question. Okay. And there's a new table again in the new shackle 4. All except. So this time they have removed your PPI. Earlier, there was a risk factor for PPI also, but now they have removed. So if you read your new shackle 4, they have mentioned alcohol is not a risk factor for adenocarcinoma, and PPI is not there in the list. I think they're, I don't think it's there in the list only. Yes, there, but 0, 0. Okay. In the previous edition, they had mentioned that PPI increases the risk of adenocarcinoma, but this time they have mentioned it as zero effect. Alcohol obviously is not there for adenocarcinoma, and PPI also. In one of your papers, I think 3, 4 years back, they had asked about PPI. So this is a new table in your new book. So every year they change the risk factors. The rest all are self-explanatory. Yes, I know. But again, you have to go by the latest edition, depending on the evidence, basically. So if you have a high level evidence, they add that there must have been some study where they must have shown that PPI does not do much harm. So earlier also, if you read PPIs, they have written that PPIs long-term causes chronic kidney disease, interstitial nephritis. But again, now saying that no, PPIs are quite safe and there's no problem, the kidneys are okay with it. So depending upon, because all these books are written on some studies, it's not that it's not somebody's imagination. It's all about studies. So some studies must have been taken place and they must have proved that PPI does not increase the risk of adenocarcinomas. That is why again they have put 0, 0 here. Okay. So this is about your Barrett esophagus is more or less the same that is there. So non-dysplastic 5 years, a long segment Barrett 3 years, indefinite give PPI then 6 months. That is okay. Low-grade dysplasia endoscopic eradication therapy. Okay. So ER followed by ablation is an effective treatment for early cancer rising in the setting of Barrett esophagus. So what we do is ablation. Okay. So that you can do with RFA. And if you have any visible lesion, we do EMR. Okay, so that should be very clear in your mind. If you have any nodule, you do resection of the nodule followed by ablation of the mucosa. So endoscopic eradication therapy. This is about your management of CA esophagus. I'm not going into that. It's kind of clear. Response to NACRT. Okay. Non-dysplastic, if it is short segment, what they say that it should be 5 years, long segment, I think 3 years. Sorry, opposite, sorry. So this is a new thing that they have added in your new shackle foot, response assessment after chemoradiotherapy in CA esophagus. What is bite on bite biopsy? Answer it's endoscopic ultrasound because we know that after radiation there's a lot of fibrosis and US is not very good at picking up fibrosis. PET CT is the, if you ask me, the investigation of choice to detect your response. Okay, so this they have taken from the Sano trial. Okay, Sano trial. So this is a trial that they are trying to see whether you can use wait and watch policy in your CA esophagus. So they are giving you chemoradiation therapy and patients who are having your complete clinical response. And this complete clinical response, how are they evaluating? So they're doing this upper GI endoscopy, they're doing PET CT scan, and then they're doing biopsy also. Okay, so what they're doing, what they are seeing is if they see a scar area, okay, scar area, and they take biopsy from that. If it is negative, then they are not very confident that whether it is actually negative or it is false negative. So the same place they do again go in and do a biopsy. It's called bite on bite biopsy, and but that they're saying that it is more sensitive to pick up malignancy. Okay, that's called bite on bite biopsy. So if you want to see a complete response, if you want to assess a complete pathological response, what we do is bite on bite biopsy, and that is they have taken from the Sano trial. Okay, so symptoms endoscopic ultrasound is not very good at. Once you radiate a tissue, US is very bad at picking up whether it is radiation induced or whether it is malignancy. Okay, same in rectum also, right? Same in rectum also. So this is about the trials, the new trials that have published apart from the cross. So cross higher PCR, we know that cross has higher PCR in squamous cell cancer. What is next trial? This is a very interesting study. No, US post radiotherapy, we don't use that. Actually, it does not work. So once you radiate a hollow organ, there's a lot of fibrosis, and US is very bad at picking up fibrosis. You do a MRI, that should be the investigation for it. MRI in rectum, PET CT in esophagus, that should be the answer. The answer here is D. We just put each option. Cross, we know that it is better for squamous cell cancer. Next is also a trial, and what is a very interesting study, I think, from China. What they have shown is that in squamous cell cancer, we know that standard of care is chemoradiotherapy, but they have used chemotherapy. Okay, so chemotherapy can be used in squamous cell cancer with non-OS, non-inferior OS compared to NACRT. So next trial is about the same thing in squamous cell cancer. They're using chemotherapy. Next trial. SOPEC is FLOT and cross. So they've compared FLOT and cross. So here they said that FLOT is better than cross in adenocarcinoma. Okay, that is SOPEC. Sano trial, they have used both. They have basically taken patients for both squamous cell as well as adenocarcinoma. Okay. Uh, this was adenocarcinoma. All patients with adenocarcinoma, one group they gave FLOT, other group they gave cross. Okay, and they compared FLOT with cross. They found obviously FLOT is better than cross. Sano is surgery as needed for esophageal cancer. That is the full form. And again, what they did, they took patients from both histologies, squamous cell adeno, treated with cross, and they saw for clinical complete response. And then they divided the patients. Suppose they took 100 patients, 50 had clinical response. This response was seen with endoscopy, clinical symptom, PET CT, bite on bite biopsy. When everything was negative, they assumed that it is a clinical response. So they had two groups. One group underwent surgery, other group was kept under surveillance. And what they found is that this group that was kept under surveillance was non-inferior to the group that underwent surgery. Okay, so that was a Sanos trial. There was a pre-Sano study, and now we have the Sano trial. Okay. So remember the new trials that have been mentioned in new book. One is your Sano trial, then is your next trial, then your SOPEC trial. So these were mentioned in your previous edition. These are ongoing, but now the results have come out. So they have mentioned all these new trials in your new edition of Shackleford. What is the false statement here? T1B, risk of lymph node metastasis. This was again a repeat question. They have asked about what is the percentage of patients who have lymph node metastasis. Recurrent laryngeal nerve, highest with transhiatal sphincterectomy. Paracondylar hernia, more common in bad sphincterectomy. So these are your new things that have been come up. It's not there in the previous book. So T1B, that is true. Uh, Around 40% chance of that is why we do esophagectomy here. We don't do endoscopic resection. Recurrent laryngeal nerve injury. So that is highest with your McNeons, not THE. So how is different THE from McNeons? McNeons we do a thoracotomy also, okay? And basically your three-field clearance that we do with McNeons. We cannot do three-field clearance with your IVLOS, okay? No, it's about the field clearance. The nerve injury happens once you do lymphadenectomy along the nerve, okay? So if you're doing a three-field clearance, so this is the only surgery where you can do three-field clearance because you're opening the chest, you're opening the neck, opening the abdomen. That is a McNeons esophagectomy. Or you do a VAT esophagectomy with three-field clearance. Okay. So highest is with McNeons. Then comes THE, then comes your this thing, IVLOS. Because you can injure the nerve in the thorax as well as in the neck. It's not that you injure the neck only. If you do a lymph nodal clearance along the nerve, you can injure the nerve there also. Paracondylar hernia, they say it's more common in VAT esophagectomy. So if you take the stomach up, okay, so if you open the hiatus here, so what they have seen is that because in minimally invasive surgery there is less adhesion, okay, so through this hiatus you can have a paracondylar hernia. So this is an observational study. They have shown that it is more common with VAT esophagectomy, and this is the new recommendation. They're saying you have to harvest 18 lymph nodes. This is what is written in your new book in CA esophagus. Okay, this is your numbers that you have to know. Sometimes they have asked about what is the risk of lymph node with squamous cells. Overall, if you see the risk of lymph node metastasis with squamous cell is more than adenocarcinoma. Okay, so overall, and these are your lymph nodal numbers that you have to remember. Sometimes they ask you about T1, what is the risk of lymph node in T1A, T1B, adeno, squamous. So they are very fond of asking all these things. So this was a table. I think this question was there in a previous year paper. So they had given this image, and this is about your reverse gastric conduit. Okay, you have to know the artery. What is the indication? Generally, we use for corrosive here, corrosive pediatric patients with corrosive injury. This is what we use, your reverse gastric conduit. Okay. The artery is your left gastropoic artery. Here the artery is right gastropoic artery, and we divide the stomach, split stomach we call it. Okay. This is again right gastropoic artery. Okay. Right gastropoic artery. So this is, I think, given in your books, and we have studied also. So nothing new here. Not true about gastric conduits. This is new term that they've defined, DGCE, delayed gastric conduit emptying. So if you use gastric conduit, what are the problems with gastric conduit is number one is reflux. And this reflux obviously is more if you do an intrathoracic anastomosis. Okay. This is the definition of DGCE, more than 500 ml of NG aspirate per day after day 5. So this is the definition that they have proposed. Whole stomach obviously will have a higher DGCE, and stenosis is more common in thoracic anastomosis, not cervical. Okay. That is a 3 or 4 points that they have given, which I thought that I'll share with you. These are the numbers. Remember, graft necrosis 5% with your colon. Okay, and anastomotic leak is 10%. Same with colon and stomach. What is this? Is all questions that have been asked. Okay, yes. So that is what they are saying, that in spite of the thing that people think that cervical anastomosis has more and stenosing effect, it is more common in thoracic. Yes, leaks are again more common in your. Yes, so leak. So there are three things: leak, stricture, and stenosis. So leak, more common in cervical. Okay. Stricture and stenosis, what they're saying is more common in thoracic. This I have to clarify. According to me, should be, stricture should look on cervical. So what they're saying is maybe because of a reflux, because of long-standing reflux, there is stenosis of the anastomosis. Okay. So remember, cervical and thoracic, how to differentiate that? Okay, cervical anastomosis, more leaks, decreased morbidity. Stenosis, the new book says that stenosis rates is more with thoracic. I think it is more due to the reflux. Because of the ongoing reflux in thoracic anastomosis, it can cause stenosis because of inflammation. That is what my interpretation is. Okay. But thoracic anastomosis, we know the leak rates are less, but the morbidity and mortality is high. And the reflux is more with thoracic. Remember that, very important. Okay, so one question is bound to come from this conduit part. Okay, so anastomosis complications, cervical, thoracic, conduit, advantages and disadvantages. Okay, so graft necrosis with your colon, leak rates are same, 10%. What is supercharging? Supercharging is arterial anastomosis to the superior thyroid or internal mammary artery. Okay, so this again a question has been asked previously. What is supercharging? And there is super drainage also. Okay, we anastomose the vein, that is super drainage. We always prefer the isoperistatic. And the previous, I think, class, somebody asked about the conduit choice. So I read about it. They have mentioned very clearly in your book that stomach should be the conduit of choice. If given an option, the first conduit of choice, whether it is corrosive or young patient, old patient, has to be stomach. The stomach is not available. Suppose it's corrosive, the stomach is damaged, then we go for the colon. Okay, so do be very clear about that. Bowel preparation, if you read your book, what they have mentioned is there was study that if you use bowel preparation before colon pull-up, that increases the leak rates, but that is not, standard. We, as per protocol, we always do bowel preparation, colon preparation. If stomach is available, go for stomach. Yeah, angiography and colonoscopy in old patients, not in young patients. Because if there was a question that was asked that assessment of the colonic vascularity, what is the best test? That is intraoperative. You clamp the middle colic artery and then you see for pulsations. Okay. So conduit length measurement is also very important. This has been emphasized in the new Shackelford. So if you see, this is how we measure. We measure the conduit along the mesenteric part. So you put a thread like this. Okay. So this is your conduit length that should be required. We always measure conduit along the mesenteric arcade. That is very, very important. This is a question that they will ask in Viva also, but they have mentioned in your new Shackelford as well. Yes, tragus to xiphoid. So what we do is first we take a thread from tragus to xiphoid cartilage, and then the same thread. First we use that thread here in the colon, okay, and then you superimpose here, and then you see this length is matching or not, okay, and then you divide it here, okay. So this length has been measured. The colonic length, how much of colon you want to take up, has to be measured along the mesenteric arcade. So this they have mentioned in new book also. All these values are very, very important. Okay? Remember this graft necrosis, anastomotic leak rates, reflux symptoms, cervical leaks, thoracic leaks, very, very important. Yes, we preserve the second order arcade. This is about the measurement, length measurement. It's called arcade preserving resection. Okay, it's called the arcade preserving resection. So there's a beautiful diagram given in your book. Okay, so this is how we divide. Okay, so we divide, you put a stapler here. Okay, put a stapler here and then cut it. We don't divide the arcade. Is called the arcade preserving colon resection in your colon pull-ups. We don't divide the arcade. Divide above the arcade. It's called the arcade preserving resection. Stenting in a stomatic leak. So I think there was a discussion about when do you stent and when do you do surgery. Generally for cervical leaks, we don't do any stenting. Overall, if you see stent, we do for stable patients who don't have any sepsis. The defect should not be very, very large, less than 30% of circumference. We always use cover stent, leave it for 4 weeks. This is again a question that was asked. How long do you keep the stent? When do you use endovac? Endovac is used for larger defect or there's any evidence of necrosis. Okay, so if you have very large defect, your stent cannot cover that. If there's a necrosis also, we don't place stents there because it will interfere with the vascularity. Okay, so what we use endovac, suppose this is the esophagus, okay, and there's a large defect here. Okay, so here we use this endovac. Okay, we put this vac here and it creates a negative pump here, and slowly this cavity will collapse. Okay, so endovac generally we don't use for acute perforations. Okay. Generally for chronic perforations. Okay, if a patient is coming say after 7 8 days and you do a CT scan, there's a large perforation that is kind of sealed. It's a chronic leaking thing, right? Chronic leaking perforation. Then we can use endovac because it will allow for sealing of the cavity. Okay, so that is how we use endovac. Covered stent generally we use for acute perforations. Okay, but remember covered stent, if the patient has necrosis and all, then people are not very fond of keeping covered stent there. Okay. So this is about the anastomotic leak. This is a very important table. Please go through it. Cervical anastomosis leak. Generally, we don't do anything here. We just open up the wound, okay, and allow it to drain, and it will heal by its own. Intrathoracic, if you have a staple line defect, then give antibiotic stent. So stent has a role. If you have a staple line defect, you can use that contain leak. So stent can be used in contain leak. If you have a dehiscence or gastric tip necrosis and the patient is stable, then antibiotics, you can use stent, endovac, chest tube drainage. Okay. Now the concept earlier, what used to happen is that the moment the patient used to have intrathoracic leak, patients were taken to OR, the conduit was taken down, and then people used to do cervical esophagostomy. The problem is that once you take down a conduit, then the second surgery becomes very difficult. So now what they're saying, since you have stent available, you have endovac available, now the emphasis is more on your conduit salvage. So they want to salvage that conduit. So if you have a conduit like this, and if you have just necrosis at the tip, rest of the conduit is fine. So here you can use this endovac. Okay, you can use endovac. If you have a small defect, less than 1/3, and there's no necrosis, you can put a stent across it. Okay, so idea is to salvage the conduit. Earlier, the routine was to put a just moment you have a leak, you just take the patient to OT, do a cervical esophagostomy. But now they are talking about all these antibiotics, stents, endovac. So you try to manage it conservatively so that you salvage this conduit. Okay, so that is what we'll call it. So if you see the definition also, the new Shackelford, even the old Shackelford, this is a type 2 conduit necrosis. So any conduit necrosis requiring surgery but not requiring esophagostomy is type 2. And type 3 requiring surgery with esophageal diversion. Okay, so diversion is basically you are taking down the whole conduit. Type 2 also needs surgery. So type 2 also, they're saying that patient needs surgery. Suppose you go in, you do a lavage and everything, but you salvage the conduit. You don't take down the anastomosis. Okay, you don't do a diversion in type 2, but you do a diversion in type 3. So this is a very important subtle difference that we have to understand. That all conduit necrosis does not require a conduit takedown and cervical esophagostomy. Okay, so some patients like this, these are the patients you can manage with antibiotic stents, endovac, chest tube drainage. So you just go and do a put lavage, put drains in, you see that the conduit is okay, there is some defect, you put a stent after that. So that is not true. So all conduit, so this is what they're saying. If you see the definition also, the Esophageal Society definition, there's a type 2 conduit necrosis where you have some amount of conduit that is necrosis, some amount of conduit that is healthy. So these are the patients where you can actually salvage that conduit with the use of stent, the use of endovac, just conservative management. So you can salvage that conduit. Okay. Type 3 is if the whole conduit is necrosis. And that is why they do endoscopy. So if you have a leak, if you have any evidence of conduit ischemia, do endoscopy and see what is the conduit like. If the whole conduit is gangrenous, you have no option, take it down. But you see only the tip is gangrenous due to mucosal ischemia, due to hypoperfusion. Only the tip is gangrenous. The rest of the conduit is fine. Don't do anything. Put a stent, put an endovac, just manage it conservatively. Let it heal by itself. What will happen is stricture formation. You can dilate it later on. Okay. But you have salvaged that conduit. That is a type 2 conduit necrosis. Type 3, Yes, if you are taking down the conduit, doing a episiotomy, that is standard treatment. So that is if you have the whole conduit is gangrenous. So that is why we do endoscopy, see what is the length of mucosal ischemia we are looking at. See, you have only tip necrosis, different tip necrosis. So here we don't do surgery. We don't take down the whole conduit if you have only tip necrosis. That is very obvious. Fundus generally has a very precarious blood supply. So it is bound to have some amount of necrosis. It does not mean that you take down the whole conduit. Interventions to reduce anastomotic leak include all except. So people have used ischemic preconditioning where they have embolized your left gastric and splenic artery. ICG is generally used in most centers. Use of divide the interclavicular ligament to have more space here. Pylotomyotomy generally has not been shown to decrease anastomotic leak rate. Okay, some centers use prostaglandin even as well. Okay, so it's given in your books. That is why I mentioned it. This patient, day two following surgery, tachycardia, BP is low, chest have a turbid output, and there's a basically leak. Okay, the whole conduit is black. What do you do? So here we cannot use stent, endovac, all these things. We have to take down the conduit. Okay. This patient has day 5 leak, fever, there's bilious output from the drain. There's a collection, there's a large defect at the side, but only dusky mucosa at the tip. Rest of the conduit is normal. Okay. So you don't take out the whole conduit here. Okay. So you try to manage this with conservative therapy. So either stent or endovac here. Okay. So covered stent, as I told you, if you have very large defect with some amount of necrosis, people are not very fond of putting stent. So here we can just drain the collection and put endovac here. So you may be able to salvage that conduit. So this is about the ECOG and Karpowski performance. This we all know, so I'll not go into it. This patient has a perforation, Boraf syndrome, 10 hours perforation. This is a question that was asked in the previous year paper only. Left side perforation, there's contamination. Patient is stable. What is the preferred management? Yes, so within 24 hours, we do a primary repair. Question that had asked about whether you should do a single layer closure or multi-layer closure. Remember, we always close the esophagus in 2 layers. Okay, so if you have a perforation in esophagus, what we do is, so this is a diagram that is given in book also. So if you have a esophageal perforation, first we have to extend the myotomy here. Okay, we have to open the common mucosa here. We close this in 1 layer, and then we close the muscle, 2 layer, and then we put a flap, 3 layer. So it has to be a multi-layer closure. You cannot close in single layer. Okay, always 2 or 3 layers. All right. So first layer is mucosa, then you close the muscle, then you put a patch. Patch is also mandatory. Okay, this is how we close esophagus. This is the question that they had asked: single layer closure, multi-layer closure. Okay. So remember, whenever you have a confusion whether this patient requires a surgery or stent, so always if you have some kind of peritonitis, mediastinitis, septic shock, surgery should be the answer. Patient is stable, contain leak, stent be the answer. Okay, it's a very simple way of knowing whether if they had asked. If the question is about whether you want to operate, whether you want to put a stent in. So if you have patient unstable, septic shock, large leak, non-contained, surgery should be the answer. Okay. If you have a patient very stable, contained leak, there's no sepsis, then should be the answer. So RAP is if you have a perforation in the abdominal part of esophagus. So suppose you have perforation here, like here, okay, abdominal part of esophagus in Borha. So here we close it and put this RAP, okay, like a fundoplication. So just to cover this thing. Yes, so you can use endovac in the post-op as well. The classical indication is a patient who presents to for day 10. Okay, after day 5 or day 6, he has a perforation, but delayed presentation. So what happens in delayed presentation is there's a perforation, there is a leak that is not very severe, and body has kind of tried to contain that leak. So it's still leaking, but the leak is kind of there's a cavity kind of thing. So that is ideal candidate because if you want to do surgery here, you will have to do some kind of a diversion. You cannot do a primary repair. So these are the patients who are ideal candidate for endovac therapy because the golden period has passed. So patient is suppose day 5 of illness, he comes to you and there's a perforation obviously. So what do you do for this patient? So there are two options. If you want to operate on this patient, then you will have to do a diversion. So you do a cervical sphigostomy, you staple off the GE junction, you put drains here, and then you do a feeding jejunostomy. So that is surgical option that you have. Okay. But if you want to manage conservatively, then endovac is a very good option. So this, I think, the previous edition it was 48 hours, but again now they have shifted to 24 hours. Okay, actually you are right. The previous edition they had mentioned 48 hours, but now they are saying again in the new edition they are gone back to 24 hours. So ideally should be 24 hours. Actually, there is no golden time as such. The tissues are very friable. Even if it is 24-hour perforation, then we prefer to do a diversion surgery. If the tissues are good, we're taking sutures, then we close the perforation. Yes, so it's a hybrid approach we call it. You put a endovac and you just do a VATS thoracotomy, VATS debridement of the cavity. So that is a hybrid approach that we use it. Okay, so it's not that one fits all hypothesis. So you have to choose your patient, and depending upon the condition of the patient, we have to decide what therapy you want to give to the patient. So this is a very confusing thing. Okay, but they're very fond of asking perforation, esophageal perforation. A question that I put in the group, caustic perforation. Suppose the patient has a caustic injury, has a perforation. So here we have only two options. Okay, if a patient suppose has a caustic perforation, say malignant perforation or a stricture perforation, okay, he comes to you. So two options. You cannot do a primary repair; it is ruled out. You cannot do a primary repair. So only two options: either you do esophagectomy, the patient is stable. So if you want to do esophagectomy, the patient has to be stable. If it is an unstable patient, then you do a diversion. Okay, so these are three very important groups. So if you have malignant obstruction, if you have a caustic perforation, if you have a patient who has a stricture and you have a perforation, so here you cannot do a primary repair because there is a distal obstruction present. So depending upon the condition of the patient, the time of presentation. Suppose presenting within 24 hours, then you do a esophagectomy, provide the patient is stable. After 24 hours or 48 hours, again there's option of doing esophagectomy. Okay, so if you have all these things, patient is stable, do esophagectomy and a delayed reconstruction. You should not reconstruct on the table at that time. Okay. If you have a patient that is unstable for esophagectomy, then you do a diversion, cervical sphigostomy, you staple of the G junction, put drains here, and do a feeding jejunostomy. So you divert the secretions basically. In achalasia cardia, again, what the recommendation is that if the patient presenting within 24 hours, you close this site of perforation, do a myotomy on the opposite side. Okay, so that is what we do in 24 hours. Okay, after 24 hours, then again we know that this perforation, this site will not heal, do a esophagectomy. Okay, so that is how we have to manage. So achalasia, you can do a primary repair, but we have to do a myotomy on the opposite side as well. So that is how we have to manage it. But suppose the presenting patient is presenting after 48 hours, then you cannot, you know that this closure will not hold. So there you have to think of a esophagectomy. Yes, primary repair with myotomy. Because here the sutures will hold. Okay, if you do a myotomy. Ideally, repair here, and suppose we have obstruction distally, so obviously it will blow out. It's common sense. Okay. If you're doing laparoscopic cholecystectomy, this is how cystic stump blowout happens. If you have a stone here, you close the step, whatever you can use hemolock, whatever you want, but this will blow out if there's a distal obstruction. That is the whole principle of surgery. That in anastomosis there should be no distal obstruction. Okay, so if you have a malignancy here, if you close it, this will blow out. You can use stapler, you can use Prolene, PDS. It has to give away. It will give away. Okay. So that is how we have to see. So if there's no distal obstruction, you close it. If there's distal obstruction, you cannot close it primarily. It does not matter the patient presenting within 8 hours, 6 hours, 5 hours, does not matter. Okay. So this is how we have to manage perforation. Very important topic. Every year they ask one or two questions. So be very careful. Read the question very carefully. Even if it is a simple question, read it. Whether it is caustic, whether it is malignant, whether I think there's a question 3 years back. The question was very simple that a patient had a caustic stricture. Patient was stable. Patient had this long segment caustic stricture, and she was undergoing dilatation and endoscopics noted that there's perforation. So during dilatation, he noticed that he had perforated the esophagus. What should they management? 2 years back, I think there's a question like this. So long segment stricture, he was trying to dilate it, perforate it. That is a very common scenario we get calls from medical gastroenterology. What will you do? Esophagectomy, obviously. Okay, there's an option of putting a stent also, but stent generally does not work in a very tight stricture. Okay, so stent can be done if you have recognized a perforation. The stricture is short segment negotiable. You are able to pass a guide wire here, then you can put a stent here. But if they ask you what is the gold standard, he has to go for esophagectomy. Okay, because within 24 hours you cannot do a primary repair because there is a stricture here. You cannot do primary repair here. So he has to go for a esophagectomy provided the patient is stable. So within 24 hours perforation, but you cannot do a primary repair with perforation. Okay, so be very clear. This was the AIMS question, I think, 2 years back. Yes, you can do. Stoma is basically cervical esophagostomy. So it is a triple diversion. So you divert here, but you can have a reflux from here also. From stomach, the acid can come here. So you have to cut off this also. You have to put a stapler here. And then you do a venting gastrostomy and then you do a feeding genostomy. Okay, so all these things can be done. So yes, obviously, the patients. No, thing is that suppose you don't have the expertise to do esophagectomy. Esophagectomy is very difficult case, not a very easy. Okay, so it's actually right that if the patient has come to you, you don't have the expertise to do esophagectomy, the safest possible would be a cervical esophagostomy, a feeding genostomy, and drains. That's all the patient requires. If you have the expertise, you do that. Okay, suppose if I'm the operating surgeon, if you have a malignant perforation, so if the patient has a malignancy, and it is a quite advanced malignancy, how can I do esophagectomy in that patient? It's very, very difficult. Leaking patients, unstable patient. Okay. So in practical real life scenario, esophagectomy is a very difficult surgery, especially in a leaking, bleeding patient. Okay. So ideally, even if it is 8 hours, 10 hours, I'll do a triple and come out. But in examination, if they ask you stable patient, if you have a caustic injury, malignancy, stricture, do a esophagectomy. Unstable patient, then you do a diversion. Never a private repair. Okay. That is the whole idea. Okay. Contraindications for endoscopy in corrosive injury include all except. So perforation you cannot do, necrosis of hypopharynx you cannot do, presentation after 96 hours you cannot do. Okay. So these are the patients where we don't do endoscopy. So if you have a say patient has a caustic injury and there is necrosis of the hypopharynx, there's a lot of laryngeal edema. So these are the sick patients. Suppose a patient comes to you, right? He's quite sick. He gives history that he has taken corrosive. You open up the mouth, you see there's a whole the hypopharynx, everything is sloughed off. Okay. Moment to put endoscope, the patient will go into cardiac arrest. Has to go. Okay. So that is why they say that why do you want to do endoscopy? What purpose will it solve? We know that the patient has a high grade injury. Your endoscopy will not seal the injury, not prevent the injury. So why do you want to do endoscopy in a grade 3 injury? Why do you want to prognosticate? We know that this is a high grade injury by the appearance of the patient. Okay. That is why people are saying that not all patients require endoscopy. Okay. So they have given two grading system. This is a new thing that they've added. So endoscopic grading system and CT grading system. So read about it. Okay. Yes. So it's not. So again, you have to take it. It's not that it should not be done. You have to do. Book says that you have to complement with the CT scan or do a CT scan and complement with the endoscopy. But for examination, just remember when not to do endoscopy. Okay. Unstable patient, we have say airway compromise. If it has perforation, it has necrosis of the hypopharynx, don't do endoscopy. So once you stabilize the patient, secure the airway, put a ET tube, and then you do endoscopy. Okay. So just remember when not to do endoscopy. Otherwise, endoscopy should be done in all patients. That is what your book says. Okay. Steroid use in laryngeal edema, that is absolutely fine. For stricture prevention does not work. Not work. So we don't do for stricture prevention, but what we use steroid in corrosive stricture is if you want to do stricture dilatation. So they use intralesional steroids. Okay. So they use this triamcinolone to give intralesional triamcinolone into stricture. Even they give mitomycin C, does not work, but yes, this is what the role of steroid is. Systemic steroid has no role in stricture prevention. Remember that. Local steroid has some role. So this I think we have discussed. Barium should be done at 3 weeks. Okay. Once you have a 2B and 3 stricture, Your stricture rates are very, very high, 70%, 90%. The stricture presents at 8 weeks. Okay. So why do you want to dilatation? So that is what we said. Once you have a corrosive injury, your barium is in a 3 weeks, and then you start dilating at 4 to 6 weeks because the stricture forms at 8 weeks. So you don't want to dilate after the stricture forms. You want to dilate before the stricture forms. Okay, so this is the timeline. Remember, 3, 4, 6, 8. So if you don't do anything at 8 weeks, the stricture will completely form. So that is why we do a barium C for narrowing and start dilating at 4 to 6 weeks. Okay. What is dilated that we use? Savory dilator. Okay. These are all MCQs. Okay. Savory gala dilator. Dilatation starts at 4 to 6 weeks, and intralesional triamcinolone and mitomycin are used in some cases. Okay. So this was the conduit, I think. If the stomach is spared, it is generally the preferred conduit as it has an adequate and consistent blood supply, single anastomosis, and all those things. Okay. Problems with colon is that preoperative bulk preparation is required, less predictable arterial anatomy, propensity for venous congestion, increased operative time, two additional anastomosis. Okay. So remember, if available, use stomach. FG is not done after 3 weeks. FJ we do in immediate period. If the patient comes to you with caustic injury, high grade injury, we do FJ after 3 or 4 days. So this is about your risk of malignancy. So these are new figures that they've given. 1,000, 3,000 more likely to develop malignancy. More common is squamous cell cancer, not adenocarcinoma. Is also there, but squamous is more common. Incidence of 2%, 30%. Okay. Occurs at the tracheal bifurcation, which is a site of anatomical narrowing. And generally, it occurs 10 to 30 years after caustic injection. So all these numbers should be very clear. They have mentioned this was there in the previous, I think, papers also, but now they have incorporated in the chapter as well. New chapter on caustic injury. Oropharyngeal. Okay, so this was a question, I think, about caustic injury. Suppose you have a high corrosive stricture. High means that it is at the level of upper esophageal sphincter and above. Okay, so there's a stricture at the cricopharynx. If you ask me, this is the upper esophageal sphincter. So what will you do is, suppose you have a stricture like this. This is the UAS. So your anastomosis should be at the pharynx. Okay, obviously there's a stricture here. You cannot do below the stricture. So we have to do a colopharyngeal anastomosis. Okay. So for colopharyngeal anastomosis, preoperative work is DL and hypo. We do direct laryngoscopy and hypopharyngoscopy. We want to see whether this pharynx is available for anastomosis. We look for the piriform sinuses as well, because this is where the anastomosis happens, either in the piriform sinuses or the posterior pharyngeal wall. So it makes perfect sense. If the stricture is here, your anastomose above that. What is above that is pharynx only. Okay, so this is where your colon will come, and you join like this. Okay. The problem with colopharyngeal anastomosis is aspiration. Leak rates are not very high because pharynx has a very good blood supply. Colon is okay. So it's not that this anastomosis is very prone for leaking. Leak rate is standard 10, 15%, 10%. That is okay. But the problem with this anastomosis is that there's aspiration risk. Okay. So there's a risk of microaspiration. And that is why if you're using a colon pull-up for a patient, we have to take a consent for tracheostomy before the surgery. So number one is your aspiration. So if preoperatively they ask you, what are the things that you do? You take consent for tracheostomy. There's a risk of microaspiration and speech therapy. These patients are not able to phonate properly. So they have to be, sent to a speech therapist, and probably with deglutition. So they cannot eat also. So all these things have to be, counseled to the patient. All right. So these are the things with colopharyngeal anastomosis. Morbidity is high because of aspiration, because of delayed speech, because of delayed phonation. Okay, so that is a problem with your this thing, colopharyngeal anastomosis. All right. Coming to peptic ulcers, management of bleeding peptic ulcers. For now, this chapter has been greatly simplified. So earlier they had given multiple options, but this time they have written a beautiful chapter on peptic ulcer disease. So after the examination, maybe you should read that. So TB with pyloroplasty, So this is the treatment for bleeding duodenal ulcer. Okay, so this we have discussed. That is the most, logical surgery, if you ask me. You close the duodenum in transverse manner. You do a pyloromyotomy, pyloroplasty, and add a truncal vagotomy. For gastric ulcer, obviously gastrectomy is the ideal if the patient is stable because there's a risk of malignancy here. Usage, more only 10% requires surgery, 10 to 15%. So 85% you can manage with endoscopy. Okay. Non-operative treatment is a very important thing. So you see a lot of peptic ulcer perforation in your general surgery days. So when do you use a non-operative treatment? Yes. So if you have an ulcer, which is more than 24 hours and it is kind of a seal perforation, patient is not fit for surgery, old age, you do a contrast study, there's no leak, then you can use your non-operative treatment. But we know with gastric ulcer, there's always a risk of malignancy. So that is why they say that if the patient, we know that it is a gastric ulcer perforation, then this patient should be operated, even if there's no leak. Okay. Patch repair of peptic ulcer perforation, they're in all except. So if you have perforation, your natural tendency is to do a patch. You just do a patch repair. But it is not the standard treatment for ulcer. Okay, it's not the standard treatment for peptic ulcer. Remember that. So when do you do a patch repair? Standard treatment. So if you have a say gastric ulcer and you have a duodenal ulcer, okay. So for duodenal ulcer, the standard treatment should be remove that ulcer. Okay, so should be done. What we do is and should we do antrectomy. So that should be standard treatment for duodenal ulcer. But patch repair is done if you have an ulcer and we know that it is due to H. pylori. Patient has not taken treatment for H. pylori. So you just close the ulcer and then give treatment for H. pylori in the postoperative period. So that is the classical indication. Patient comes to you has a duodenal perforation, and you know that patient has not been treated for H. pylori, then you just patch it and treat it for H. pylori. If you have NSAID-induced ulcer, you know that this is due to drug abuse, you just close the ulcer and ask the patient not to take NSAID. So you don't have a recurrent ulcer. So these are classical indication. Third indication, unstable patient. So the patient not stable for surgery, you cannot do a formal antrectomy and all those things. Then you obviously have to do a patch. Does not matter where the perforation is. Okay. Type 2 gastric ulcers, again the same thing. You can type 2 and duodenal is almost the same. So you do a patch repair. Type 3 gastric ulcer require antrectomy. Okay. Require, this is clearly written in your book. Earlier it was in type 2 and type 3. Yes. So now they are saying is type 2, yes, you can do a patch. For type 3, they say that if you do a patch repair, they will have a gastric outlet obstruction in the post-operative period. So they're saying for type 3 gastric ulcers, always do a resection. This is about the gastric ulcer. So if you have a gastric ulcer, the basic thing is that you resect it. Okay. You do a gastrectomy because there's always risk of malignancy. So if patient is stable, do a gastrectomy. Unstable, then only you can think of a patching it. This time they have talked about a lot of laparoscopic repairs. So laparoscopic repair of perforation. So they are talking about this boy score. Okay. So this thing about boy score. And this, what are the factors in boy score? Shock on admission, ASA grade 3, 4, and prolonged perforation. So this is where we should not do a laparoscopy. Okay. So about patch closure is seen with initial presentation during ulcer, especially if H. pylori, acute NSAID, and perforation in the setting of shock or delayed presentation. Patient has a lot of comorbid illness. This is where we do a patch closure. Okay. What is double track reconstruction? This was a question that was asked in one of your papers. DTR, proximal gastrectomy. So what they do in DTR is, so suppose the tumor is at here, at the cardia, they do a proximal gastrectomy, all right? So you have this stump that is left, okay? And then they do a Roux-en-Y esophagogynostomy like this, okay? And then they anastomose this thing with your Rulu, okay? It's called a DTR. So this is basically kind of a conservative surgery where we want to preserve the stomach and all, but we don't do for advanced gastric cancer. We do for early gastric cancers. Yes, because if you want to do if you have advanced gastric cancer, then you have to do this lymphadenectomy, because here we have preserved this distal part. So obviously, your arteries are preserved here. Okay, so if you want to do a lymphadenectomy, you have to sacrifice the artery. Okay, so for advanced gastric cancer, we have to do a D2 gastrectomy. For D2 gastrectomy, all these arteries will go. Okay, so that is why you cannot do for early gastric cancer. What we do for we don't do for advanced gastric cancer basically. So this is about the thing that we had discussed right from our early days. What is D2 gastrectomy, what is D1 gastrectomy, and D1 plus gastrectomy. Okay, the same thing that they had. It's there in your all the books, all the classes that we have taken earlier. What is D1, what is D1 plus, what is D2, what is D3 gastrectomy. So one more thing, what is D3 gastrectomy? So this is D1, okay, up to 7. This is D1 gastrectomy. D2 is up to 8A, 9, and 11. Okay. 8A and 9 is D2, and 12 and 11P is a D1 plus, and this is D2. Yes, D3 is taking, if you take the irritable lymph nodes as well, that is D3 gastrectomy. So, okay, so this is, you have to know D2, D1, D1 plus. So they may ask you about D1 plus gastrectomy, because D1 you know what is D1 plus. D1 plus is taking your celiac and hepatic artery lymph nodes. You take station 9 and 8, that is D1 plus. D2, if you clear up the hepatoduodenal ligament, station 12A, and clear up the 11, the splenic artery lymph node, that is your D2, complete D2. You don't take station 10. The station 10 has been removed from your D2 lymphadenectomy, correct? So this is the trials that they mentioned in your book. D1, D2 Dutch trial, no difference in survival and improve. No. So standard of care for CS stomach has to be perioperative, magic or flood. We don't do a front surgery. So why do you want to do a D2 gastrectomy? There's improved disease-specific survival. Still now they have not proved that there's difference in overall survival. Only thing is there's improved disease-specific survival. Disease-specific survival. So 16 lymph nodes, chemoradiation, no role, but yes, you have the McDonald's regimen, still practiced in some centers in US. They use chemoradiation. As I told you, there's a role of neoadjuvant immunotherapy, nivolumab, in MSI-H tumors. And you have the checkmate trial, they were using adjuvant nivolumab. Okay, so even chemotherapy, patient has residual disease, they give adjuvant therapy with immunotherapy as well. Yes, this is a new thing that they have added, giving neoadjuvant immunotherapy. So you have the Matterhorn trial about GE junction cancers. Okay. Yes, keynote is basically a lot of trials. They have a lot of keynote trials. They have keynote trial in biliary malignancy also. Different types of immunotherapy they have used in the keynote trials. So you have keynote and checkmate. These are two trials if you see in immunotherapy that is there. Just I think it's very simple. So only thing is that we have to know this new thing that has come up here, succinate dehydrogenase gene. This is a hereditary form for GIST. And what is the importance of SDH gene? Second importance is we have to do lymphadenectomy. So in pediatric GIST, we have to do lymphadenectomy. Okay, so this hereditary GIST generally presents in the pediatric period, and they have this SDH gene mutation. So where we have to do a lot of lymphadenectomy. Generally in GIST, we don't do lymphadenectomy. But in pediatric GIST, in patients who have SDH mutation, we have to do lymphadenectomy. So this is one thing that we have to know. High risk feature of GIST, again a repeat question asked many times. Answer would be D. I don't think they have a good prognosis, because since we're doing lymphadenectomy, it means that it has a lymphatic spread. Once we have lymphatic spread, it has to be a very dismal prognosis. So this is your Johnson modification of NIH classification. So this everyone knows, although there's high risk, intermediate risk. I'm not going into this thing, but remember this is the one question where one area of just where questions are generally asked. Okay, this is a new table that they have asked about. Okay, so what are the, if you have a gist here, what surgery will you do? It's very simple. So if you have a gist here, small gist, you do a wedge resection, large gist, you have to do a gastrectomy. Here, again, answer would be distal gastrectomy. Here, wedge resection or a proper gastrectomy. So there's one thing that to know in cardiac gist, if you have very small gist here, so treatment it will be a total gastrectomy. Okay, but if you want to avoid total gastrectomy, they use this laparoendoscopic resection. So what they do is, they put a trocar here, okay, put a balloon trocar, inflate the stomach, okay, yeah, intragastric balloon, inflate the stomach, and then they go in and take the tumor out. Okay, so it's called laparoendoscopic resection. If you have a gist on the lesser curvature in the cardia, because otherwise this patient will require because it is near the GE junction, he will require a total gastrectomy. So to prevent a total gastrectomy, because here we're doing organ preservation, you put a trocar in, inflate the stomach, and take this out. It's called laparoendoscopic resection. All right. So this mutation, we know it has resistance with GIST, and this is the drug that we use. Avatinib, I don't know how to pronounce it, but this is what it is used if you have this type of mutation. R1 resection is accepted. GIST less than 2 centimeter, if it is a gastric GIST, you can observe it. Non-gastric, we have to resect it. If you want to give chemotherapy, has to be given for at least 6 to 9 months. So these are a few points that we have to remember in GIST. Maximum difficulty in doing ERCP, even by gastric bypass. Okay. Morbid obesity with Crohn's, what is the preferred surgery? So the best surgery is sleeve gastrectomy because it has the least risk of malabsorption. Sleeve, yes, okay. Which of the following mitotic count and Ki7 index has the, okay, so if you have a grade 2 NET, so which of the following fits this grade 2 well differentiated NET? Grade 2, yes, P, 2 to 20 and 3 to 20%. Good. Okay, so only thing is that you have to know what is a neuroendocrine tumor and what is a neuroendocrine cancer. These are the gastric carcinoid types. You know that 5-HIA for carcinoid syndrome. This was asked in one of your papers. False statement. So basically, to diagnose carcinoid syndrome, we use 5-HIAA. Okay, it is a 24-hour urinary measurement that we use. Problem is that there are some drugs, some foods that can lead to spurious levels of 5-HIAA. So you can avocados, bananas, and all these things. So people say that you should avoid this thing if you are, because that is metabolized for tryptophan and serotonin. So that you should avoid. Okay. If you have foregut carcinoid, these carcinoid don't have the enzyme to manufacture 5-HIA. In spite of this patients having carcinoid syndrome, your 5-HIA levels are normal because you just don't make that 5-HIA. PPI has to be stopped 7 days before measurement. So this is for chromogranin, not for 5-HIA measurement. Okay, because PPI can affect your chromogranin levels. PPI, renal failure can affect your chromogranin levels. So stop the PPI for 7 days before doing a chromogranin measurement. Okay, and this drug is used for refractory diarrhea. Remember the drug telostat. I don't know how to pronounce it, but this is the drug for refractory diarrhea. So for small bowel carcinoid syndrome is also a very hit topic. Okay, so every alternate year they ask questions about carcinoid syndrome. So remember in foregut carcinoid syndrome, you don't have this, even if the patient is having carcinoid, we don't have this levels in the urine because they don't manufacture this thing. Okay, the foregut carcinoids. Okay. Now there was a question on your stapling technique, suture technique also. Okay, which of the following technique does not incorporate the full thickness of bowel? Okay, what is Gamby stitch? What is Condon stitch? Lambert, Lambert and Halstead both. Okay, so Lambert and Halstead are same thing only. Okay, Gamby is full thickness. So if you're using bowel anastomosis, this is basically a full thickness stitch. Okay, so you go from here like this stitch. Okay, full thickness stitch, and the knot is inside in Gamby stitch. Cornell we use in bowel anastomosis. So how does Cornell use? You go from outside in, inside out, outside in, inside out, then you stitch. For corners we use the corner stitch. So it is an inverting stitch. Okay, corner stitch. These are all full thickness stitches. Okay, Lambert is partial thickness. We just take the serosa and the muscular layer. We don't puncture the mucosa in Lambert. Halstead is also same thing. It just is a horizontal mattress Lambert. So we go like this, and then we suture it. Okay. Yes. So we don't uh, go through the entire bowel thickness. So this question was asked in one of the papers. So therefore, I thought that you should know about a bit about stitching also, different type of stitch, Gamby, Cornell, Lambert, Halstead. Yes. So Gambi is basically a full thickness stitch, but I think the knot is inside the mucosa, as far as I remember. So it is an inverting stitch. So we go from mucosa outside, then from the outside we come inside and tie it like this. So it inverts the bowel like this. This is a case of midcut volvulus. Not volvulus, it is just malrotation. Why it's not volvulus? This is about pediatric surgery. I don't know much about pediatric surgery, but this is a question for you people. Yes, the abdomen is soft. Okay, so if you have a patient, so you have to differentiate whether this patient has a malrotation with volvulus. So in volvulus, patient should be, patient has a risk of ischemia or gangrene. The abdomen should be distended, maybe metabolic acidosis, a sick patient. So what are the radiological signs of volvulus? Whirlpool sign. So by the way, how to diagnose your malrotation in small babies? Swirl sign, whirlpool sign, yes. So what's the test to diagnose? Do a CT scan here? No. For babies, you don't do a CT scan. You do oral contrast study and then see where your duodenum is. Yes. So in babies, generally, we don't like to do a CT scan because number one is that we have to sedate the patient. Yes. We do a contrast study. Okay, we do a contrast study. So you have different types of malrotation: classical, isolated secocolic, and reverse rotation. So malrotation, please read about it. It's a very important topic. Okay? You can have a malrotation in young patients. You have malrotation in babies, and then you have a malrotation with volvulus, intestinal rotation, derotation. So they're very fond of asking this, okay, in small bowel. And it can just spill into pediatric surgery as well. So that is very, very important. So upper GI contrast study is a gold standard. And what we see, DGA flexion on the right of spine, you have a corkscrew appearance, gasless abdomen because the obstruction is at the level of duodenum. So that is why they have a gasless abdomen. Whirlpool sign is sign of volvulus. This is what we do in your lat surgery. Detorsion of the volvulus, divide the lat bands, widen the base of mesentery. And this is where you put the small ball is on the right side and colon is on the left side. So this is a question that is often asked. Once you do a LATS procedure, where is a small ball kept? It's on the right side and colon is on the left side. So basically the embryological position that this is what we put. Appendectomy is not mandatory, it's optional. Okay. This is the last question. 40-year-old patient, divergent ileostomy, and he has unrecovery and discharge. What do you advise in patient? Suppose you have done ileostomy for a patient. What is the post-operative advice that you give? So only thing is that you have to tell the patient that he may have a high output fistula that is seen in 20% of patient. What is the dietary advice that you give the patient? Prevent that, dehydration and everything. What do you advise? You advise these patients to be on high fiber diet. You give them PPIs, okay? Bulking agents we give, stool bulking agents, okay? We give them PPIs because this acid will, high fiber content into diet basically, not fluid, okay? Here, if you read your new book, they have mentioned that you should not advise to take them hypertonic solutions with high salt content. Okay, you take advice to these patients to take hypotonic solutions. Okay? Hypotonic, not hypertonic. Okay, what they say that if you take hypertonic, the diarrhea will increase. Okay, or isotonic is okay. When do you give hypertonic saline in short bowel syndrome? Hypertonic saline, if you give only the patient has hyponatremia only. Okay. So you advise them to take hypotonic or isotonic. Okay. So they can take isotonic ORS solutions, but we don't. So what happens is that they are very fond of eating salt and lemon and everything. They put a lot of salt. That will cause more dehydration. Okay. So advise them to take water or isotonic solution. not hypertonic solutions. So these are the post-operative complications after ileostomy. So one is your high ileostomy output. Sometimes once you mature the ileostomy, you see that it looks a bit of dusky. So what we do to confirm whether this duskiness is above the skin or below the skin, we do a tube test. Okay, so this is the test that we use. So if you put a tube, light a torch, see the mucosa below the skin. If it is okay, there's nothing has to be done. So if the mucosa below the skin is dusky, then you have to reoperate. If it is the mucosa is dusky above the skin, then you can observe after some, you can put some mannitol or glycerin, the edema will settle and the mucosa will become normal. You can have separation of the mucocutaneous junction. There's an increased risk of polylithiasis because of the bile acid malabsorption because you have resected the ileum or you have diverted it. So you have a intrahepatic circulation of bile is affected. You can have prolapse, you can have stenosis, parastomal hernias. What is this? This is pyoderma gangrenosum. Okay, you have to rule out Crohn's. Yes. Okay, so we stop here. I think you should study. Just wanted to discuss a few questions with you. Maybe we'll have a class tomorrow also. We'll solve some few questions. Okay, some new